I had interest in pregnancy, in connective tissue diseases in general, especially lupus, and I have been running this clinic for more than 25 years. So I don't run the clinic alone. So it's a combined clinic. So we see the patient together. I see the patient with the obstetrician, obstetric physicians, neonatologists, because if when we predict there is a premature baby, we involve them at early stage. And for the antiphospholipid syndrome, clinical hematologists. So it's a very combined multidisciplinary clinic, which is always a good thing to do if you have the facility to do that. I'm sure not all hospitals can do this, but we are at St. Thomas's Hospital Referral Center for Lupus, and therefore we will able to do this, okay? So over the years, over the last 25 years, we saw thousands of patients, especially lupus and antiphospholipid syndrome, as you can see from the slides. And I gained a large experience in the management of this challenge, which is the lupus patient in pregnancy. And in the next lecture, I'll tell you about antiphospholipid syndrome in pregnancy. What is lupus, okay? Lupus is a variety of manifestations. Some of them are mild, like skin rash, joint pains, fatigue, and they have antinuclear antibody, mouth ulcers. They have butterfly rash, even beautiful rash. That patient comes through pregnancy, and I tell you, they do as good as the general population. They don't have any major problem in pregnancy. This patient has lupus as well, but this patient have severe lupus, which is affect the kidney, affects the brain, affects the lungs, affects the heart, and this is why it's called systemic lupus. This is the real lupus. This is a wolf. The word comes from lupus, wolf. They compared the skin rashes like the bite of the wolf. This also comes to you to look for pregnancy. This is high risk, okay? Both of them are called lupus, but it's not the same, one and another. And these patients shouldn't compare themselves to each other as well. The prognosis of this patient in pregnancy is much worse than the first patient, and she's likely to face a lot of problems during pregnancy. To make life even more difficult, lupus is a disease you have flares and remissions, flares and remissions. Look at the patterns, flare and remissions. This is the typical, unfortunately rare way of presentation of lupus. You have symptoms, you diagnose with lupus, you treat with steroids and anti-malaria drug, and the patient go into remission for a long time. That's very rare, unfortunately. Unfortunately, very rare. The typical lupus patient is this: flare, remission, flare, remission, flare, remission. And there is a third group. These are 70% of the patient. And the third group, whatever you do, the disease remain active, okay? So ideally, if you would like to consider pregnancy, the pregnancy should be here, when the patient is in remission. But most of the time, unfortunately, the patient comes to you when she is in flare, or the patient is chronically active anyway, and you have to handle them. They also want to fall pregnant, okay? So these will do very well, but this group of patients very likely to face complications in pregnancy. So what to predict? What make pregnancy high risk? These are tips what make pregnancy high risk. Lupus nephritis, even previous lupus nephritis, past history of lupus nephritis is high risk, and I show you data on that. Antiphospholipid syndrome, which I told you about later. A previous history is very important. If a patient has 6 miscarriages, she's likely to have more miscarriages, independently of lupus, independently of antiphospholipid syndrome, high risk. Cardiac involvement, pulmonary hypertension, hey. In the past, they used to tell lupus patients don't fall pregnant if they have kidney disease. Not anymore. But pulmonary hypertension, if severe pulmonary hypertension, you know what happened? The patient might die during pregnancy. So this is, for me, an absolute contraindication if it's severe pulmonary hypertension, because the patient is risking her life during pregnancy. Active disease at conception is a risk factor, and I tell you about extractable nuclear antigens in a minute, because they have a special risk factor for neonatal lupus. So what's the potential problems that lupus flare during pregnancy? That's important, because many of your patients will stop their medications because they read that you shouldn't use these in pregnancy. They read the prospect of the drug. They tell you, I am taking a drug, but they don't take it. They go home, they don't take the medication. Many of the patients flare during pregnancy. Miscarriage and stillbirth. 20 to 25%. This is much higher than the general population, mainly due to lupus nephritis and antiphospholipid syndrome. Premature birth of the infants, 25%. Some of these premature births are iatrogenic because we are worried about that patient and we finish pregnancy before 37 weeks. But hey, it's still high percentage. Preeclampsia, very high, 3 times more than general population. And neonatal lupus is a risk in Rho positive mothers. What happens if the patient have previous history of renal involvement or active renal involvement? These patients are at increased risk, dramatic increased risk of preeclampsia, intrauterine growth restriction, and preterm delivery, whether the disease is active now or previous history of lupus nephritis. And I'll show you data on that in a minute. Even if the disease is in remission and the previous history of lupus nephritis, they are at risk of these complications. The risk is higher if the creatinine at baseline, i.e. at the beginning of pregnancy, is high. The chances of successful outcome is obviously it's better if the serum creatinine is low. And if the disease is active, ideally, it doesn't happen in real life. They come to you, are pregnant, I am pregnant, and you have to handle that. But ideally, delay pregnancy for 5-6 months until the disease is, I won't say in remission 100%, but it's better controlled, if you can, okay? This is the largest systematic review ever done in pregnancy, comparing lupus patient with nephritis versus lupus patient without nephritis. You see there, nephritis and without active nephritis and previous history of nephritis, okay? So what's the complication you expect? With active nephritis, premature birth of the infant and hypertension, and previous nephritis, hypertension and preeclampsia are increased significantly. So this is a systematic review for everything has been published in lupus and lupus nephritis for many years. So we have enough data to support what I am saying. Is the same in my experience at St. Thomas's Hospital? Yes, we have thousands of patients, as I told you, and in this publication we took into account those patients who delivered at St. Thomas's Hospital with us, because we are a referral center. We see patients who, some of them don't deliver with us, deliver locally in Brighton or elsewhere. So I took into account in this publication those who delivered with us, which we know the weight of the baby, we know how they performed in pregnancy. If you can see, SLE with nephritis, SLE without nephritis, preeclampsia much higher in patient with nephritis. Premature birth below 34 weeks, much higher in active nephritis. It's before 37 weeks, which is just prematurity, not severe prematurity, higher in lupus nephritis, and small for gestational age, higher in lupus nephritis. So similar to the international literature which I showed you previously. Now, one of the dilemma that you're going to face in a patient known to have lupus nephritis is increasing proteinuria. In pregnancy, this is physiologic. Just to increase a little bit of proteinuria is quite physiologic. The challenge is to distinguish between preeclampsia and nephritic flare. It's very difficult, extremely difficult. You have to be a skillful clinician to distinguish between the two. From clinical point of view, obviously preeclampsia doesn't give you a clinical manifestation, joint pain, skin rashes. This is to do with lupus. So you have to rely a lot about disease activity outside of the kidney as well. Cast in urine will help you a lot. You know, preeclampsia shouldn't give you cast in urine. So cast in urine, urine sediment is very helpful. Uric acid doesn't go in lupus up, but in lupus nephritis, it doesn't go up. And preeclampsia is a good marker, as you know, for preeclampsia. So we use some markers. But the final decision is not always easy. And sometimes you can have active lupus and preeclampsia at the same time. So the decision should be taken always by the obstetrician whether you terminate that pregnancy or not. If there is any doubt about preeclampsia, the physician, my physician at least, they prefer to deliver prematurely at 35, 36 weeks rather than risk pregnancy. Obviously, we use ultrasound and we use Doppler to predict preeclampsia, especially in the 3rd trimester. It's very routine in my hospital to use uterine artery Doppler scan, as the negative predictive value for these Doppler is very good. What's the meaning of the negative predictive value? I.e., if I do a Doppler scan at 20, 22 weeks, and this Doppler scan is normal, I can reassure that lady that she might do very well in pregnancy. If the Doppler scan is abnormal, like notching there, like I'm not going to teach you about that, you know more about this than me, is bad prognosis, but not 100%. So the negative predictive value for a positive scan, i.e. normal scan, is much better than the presence of notching there. It's useful, and we use it, okay? Now, what you do for active lupus nephritis, I'm not going to dwell on the drugs that we use because my third lecture will be dedicated to that, which is safe and which is not safe, which is compatible, which is not compatible. Obviously, we have schemes. I publish all the time about this, and I gave you some references about guidelines, how to manage pregnancy in lupus, European guidelines. You have it references in my abstract book, and I'm not going to dwell on that, and I leave the drugs for later in my third lecture today. Now, let me just dwell a little bit about neonatal lupus. Neonatal lupus is something that you are going to face, very rare. When it happens, it's frightening because the mother will have babies with rashes like these, which I'll show you another examples as well. But what's frightening is not the rashes. The rashes will go away, I promise you. These, despite being very heavy rashes, they won't be there forever. It's to do with the passage of raw antibodies, raw and low antibodies from mother to the baby, and these rashes 3-4 months later will disappear and never again. The baby is not sick. This is the immunity from the mother passing to the baby. The baby have reaction to the sun, and they will disappear and never again. The problem is here. The problem is cardiac. When these antibodies pass from mother to the baby during pregnancy, cause damage to the heart, and sequel for that, congenital heart block. This is much more serious complication, and unfortunately there is no way we can prevent that for now. There is no evidence that drugs work, although we have some data to suggest hydroxychloroquine might work, which I'll show you in a minute. The risk for this is 2% of the affected child. Should this stop the mother falling pregnant? The answer is no, okay? And why is that? And I always, when I counsel these mothers during my pregnancy clinic and counseling clinic, I receive many mothers for counseling before they fall pregnant. I ask them, do you know what's your chance if you are normal population to have serious malformation during pregnancy? 3.5%. And you know that, okay? So, but nobody, think of that. They get married, they have babies, and the general population get married, have babies, and you never think that your chance of having malformation, serious malformation in a baby, 3.5%. So 1 to 2% is acceptable risk. But if the mother asks me, okay, is this high risk? The answer is extremely high because heart block in the general population, 1 in 20,000 deliveries. I work currently in Dubai. What's the meaning of that? We need to have 20,000 deliveries to have one baby with heart block. So if you put in relative terms, 1 to 2% is extremely high compared to the general population, but shouldn't stop the mother falling pregnant because it's acceptable risk, 1 to 2%, okay? This is the rashes, just to promise you, this is very, very alarming for the mother. She should know about it before she falls pregnant, because if you take this to the GPs, they don't know what is this. They will label this as fungal infection, dermatitis, eczema, you name it. But it's none of the above. This is neonatal lupus, and especially if the mother is asymptomatic. Sometimes the first symptoms in the mother is neonatal lupus. The mother doesn't know that she has raw antibodies and have neonatal lupus. It's the same baby 3 months later, disappear and never again, never again. The baby is not sick. As I told you, the heart block, this is more complicated thing. It appears usually around 18 to 28 weeks of pregnancy, when the passage of autoantibodies from the mother to the baby maximum. You require the FC receptor for the antibodies to pass from mother to the baby. So it's never happened before 18 weeks, never been reported before 18 weeks. So we maximize the screening between 18 to 28 weeks. Fetal bradycardia, the midwife will tell you the heart of the baby today is 50 instead of being 150, 180. Heart block, too late, okay? 50% or 60% of those survive, they need pacemaker, especially after the first 6 months after delivery. Many of these babies require pacemaker. Currently, there is no treatment to prevent this. Now, there's mothers, they come to my clinic saying, well, I have baby with heart block, I would like to have another baby. What's the chance for my second baby to have heart block? It's not 1% anymore, 20%, 20%. It goes up to 20%. If you have I have done systematic reviews published there, you have the publication there of 1,400 babies published in the literature about heart block to have more data about that. So 1 in 5, 20%, is worth having some kind of treatment, because 1 in 5 babies will end up with heart block. It's something that you need to handle, and you need to give them some hope and some kind of treatment. So it occurred to me, based in animal model, showing in the animal model you can stop the passage of Rho and La antibodies from the mother to the baby, both Rho 52, there's 2 rows, 52 and 60, and La antibodies from mother to the baby. If you give the animal IVIG, you stop it. Why we don't do this trial in humans? IVIG is safe in pregnancy. I did it. It took me 5 years to recruit mothers who have baby with heart block, would like to fall pregnant again, to give them IVIG. And we failed. Failure, okay? First word, failure. We gave IVIG week 12, 15, 18, 21, 24, which is the highest risk period, and we failed. The American did the same. They used the same protocol, and we published, in fact, the same journal at the same time, and they failed as well. So IVIG did not protect. We have theory why it didn't work, because we gave very little IVIG, only 1 day instead of 5 days during this period. We wanted to repeat the study again, but it required a lot of funding and a lot of effort and a lot of money to do this, and we were not able to do it. But it occurred to us, hey, this is the only 2 studies around the world in any language. They are prospective studies looking at this trial. Why we don't mix these 2 studies together to see what will happen? And surprise, the target of the study was IVIG. But some of these patients have lupus, Sjogren's syndrome. They were receiving hydroxychloroquine. And to our surprise, those who were taking hydroxychloroquine, by chance, they have 0 heart block. 0 heart block. None of them heart block. The study was for IVIG, I remind you. So it wasn't targeting heart block with hydroxychloroquine, but we figured it out that, and we published this in Circulation, and clinical trial ongoing now while we are talking, trying to show that a cheap drug, hydroxychloroquine, which is safe in pregnancy, might be able to prevent heart block in these mothers with Rho antibodies with previous history of heart block. So the study ongoing is open study, obviously. You cannot blind this kind of study, and I know the result so far is very good. Thank you very much. I leave it there.